Rapidly progressive glomerulonephritis or crescentic GN. It is basically a GN when turned to very severe sort of acute renal impairment. Within days to weeks, you call it the RPGN. Notorious behavior. So when the crescent is to have the severe sort of impact on the renal outcome must be 50%. That is what they target your standard like. When if more than 50%, you have crescentic GN level like. When less than 50, you can call it crescent with some GN. And so it is also important clinically. But when someone has more than 80% of the glomerulus involvement, you have serious sorts of acute injury, kidney injury. So acute renal failure or acute renal injury. So RPGN without crescent is also possible. Same sort of presentation without crescent. Yes, a severe acute insult, the henoxylon purpura, acute tubular interstitial nephritis, and some of the cases of diffuse proliferative GN that do have RPGN-like presentation without crescent. This is exactly the same presentation. So synonymous with crescent is not true in all the cases. Causes over here are the common causes in the immune complex GN. The infectious GN is by far the commonest. Post-streptococcal, B virus, Hep C virus, HIV, shunt, and other nephritis, systemic disease like lupus erythematosus, IgA vasculitis, tubular interstitial nephritis, and even minimal change disease. Primary GN with IgA nephropathy, C3GP, and membranous GN, C1q nephropathy, they can cause C3GP-like presentation. Post-immune disease like in 90% of cases, you have ANCA positive GNs, MPGN, macroscopic polyangiitis, GPA, renal metastasis with polyangiitis, EGP, asthma-like presentation, and renal limited vasculitis. So, and few more other entity can have your C3GP like the GBM antibody disease like GPA, and your post-transplant Alport syndrome 5% of cases can have RPGN-like presentation. Simply post-transplant cases with your IgA nephropathy and IgA vasculitis, lupus nephritis, MPGN, they can also have RPGN-like presentation. So crescentic GN is not exactly synonymous with RPGN. Rapidly progressive glomerulonephritis, GN turning to sudden severe acute sort of kidney injury is called RPGN. Diagnosis, obviously it is a renal biopsy find. So crescents means they're comprised of what? The parietal cells, visceral epithelial cells, then fibroblast and inflammatory cells and cells, and your coagulation proteins of inflammation, cytokines and chemokines, they all comprise your cellular crescent. When this epithelial cell, visceral and parietal epithelial cells of Bowman's capsule, they compress the underlying glomerulus, it undergoes this amount of ischemia necrosis, and your cellular elements starts decreasing. They have more fibrosis is taking place, and so some of the crescents may be fibrocellular if it lasts, the process goes on for longer time, and in the long term good amount of can be fibrous. So cellular, fibrocellular, and fibrous crescent is possible. And so ultimately what happens, the patient loses the huge number of nephrons, and we know that 50% of nephron loss give rise to the creatinine elevation. So renal impairment, creatinine elevation, and renal impairment, acute severe kidney injury are the presentation of an existing GN. How to treat? Treatment is naturally aggressive and severe sort of disease. You have aggressive immunosuppression, IV methylprednisolone, your 15 to 20 milligram per kg per day, 3 to 6 pulses, followed by oral prednisolone 1.5 to 2.5 milligram per kg per day for 1 month, and taper over 3 months, and then finally an alternate day, then your 0.5 milligram an alternate day, and another 3 months. And before you taper, you start IV cyclophosphamide. If patient doesn't improve, IV monthly for 6 pulses. Plasmapheresis, your 1 to 1.5 volume load, and every alternate day for 2 weeks. And rituximab 750 milligram per kg per day, 2 weekly for 2 doses. Finally, good amount of cases, you have your response, you have the remission of the acute severe presentation, you may have the remission of GN as well. So in those cases, you go for the maintenance therapy with azathioprine, your MMF, and your alternative prednisolone for your 12 to 18 months. And at times, you need to continue the rituximab 6 monthly or so, depends on patient response. And refractory cases should be dealt with IV immunoglobulin, infliximab, the anti-tumor. These are basically anti-tumor necrosis factor alpha antibody, and your the maintenance your newer molecules may be LM2, belimumab, and abacopan. They are useful. Finally, in this aggressive journey or this your extensive journey, whatever you call, the prognosis is not that bad. In the western side report, it is 60 to 70% return of the normal renal function, the better response with the infective cases, notably the post-infective, post-streptococcal APHGN.